This video will describe the purpose and steps involved in a tracheostomy and the potential risks of the surgery. This is general information about the procedure which is meant to help you make an informed decision. It should supplement the conversation you have with your doctor. Any discrepancy may be due to your unique situation, and you should discuss any questions with your doctor. Specific information about your diagnosis and the reasons this procedure has been recommended for you should be discussed with your doctor. In general, reasons that a tracheostomy is performed include as an alternative to keeping the breathing tube in place while the breathing machine is needed, blockage of the upper airway due to infection, trauma, vocal cord paralysis, voice box scarring, tumor, or possible post-operative swelling after other head and neck procedures, need for improved access to provide care to the lungs and airway, and severe obstructive sleep apnea, which is not responsive to other methods. A tracheostomy is a surgical procedure which establishes an alternate airway. The anesthesia plan for the procedure depends on your specific situation. The procedure will likely be done with you asleep under general anesthesia, unless your doctor has indicated a need to keep you awake. If so, you will still be made comfortable with sedation and local anesthesia to numb the area. When you arrive in the operating room, monitors will be placed and the anesthesiologist will either guide you fully to sleep or will make you comfortable with sedation. After numbing medicine is given, a small 3 to 4 centimeter incision is made in the front of your neck just below the voice box. Dissection is done to locate the trachea or windpipe, and then a small hole is made into it. A tracheostomy tube is then placed and secured to the neck with sutures or straps. Immediately after surgery, with the tracheostomy tube in place and the balloon inflated, you will not be able to talk because air will pass through the tube and will not reach your vocal cords. Because air won't pass through the nose when inhaling, you may notice reduced sense of smell and taste and thickened mucus. The balloon and tube may put some pressure on the esophagus, causing difficulty swallowing. Some of these may improve after the tube is changed, which is usually between 4 to 7 days, but may vary depending on your situation. Also, depending on your anatomy, you may be able to talk after the tube change. If you will leave the hospital with a tracheostomy tube in place, you will be taught instructions on caring for it at home. This includes suctioning your airway, cleaning the tube, changing the strap and possibly the tube itself, and skin care. If it is decided in the future that you do not need the tracheostomy tube anymore, the tube can be removed. It will then be covered with a dressing and allowed to heal. Usually this results in the hole closing. In a small group of patients where a hole remains, a minor procedure may be necessary to close it fully. Risks of a tracheostomy include, but are not limited to, general risks of all procedures such as bleeding, infection, scar formation, and the risks of general anesthesia such as stroke, paralysis, and death. Specific risks for this procedure also include, but are not limited to, tracheal stenosis, or narrowing of the trachea, accidental decannulation, or dislodgement of the tracheostomy tube from its position, pneumothorax and pneumomediastinum, which are unintended entry of air into other spaces of the chest, tracheocutaneous fistula, which is a persistent connection between the trachea and skin, and tracheoinnominate fistula, which is an abnormal connection between the trachea and a blood vessel, which can lead to bleeding. Finally, injury to other surrounding structures is also possible, such as the esophagus or swallowing tube, the recurrent laryngeal nerve, which controls vocal cord movement, and major blood vessels. Alternatives to a tracheostomy depend on your specific situation and should be discussed with your doctor. This may include not having the procedure and keeping a breathing tube in place while the need for a secure airway exists. Or, this may include a variant of the procedure, such as an epithelial line tracheostomy, which creates a permanent tract. Likely consequences if no treatment is undertaken also depend on your specific situation and should be discussed with your doctor. Possible risks of prolonged intubation, meaning keeping the breathing tube in for a long time, include damage and scarring to the voice box, which can affect voice and breathing in the future. Blockage of the airway without the alternative airway provided by a tracheostomy would lead to death. Inability to provide pulmonary care when needed may lead to blockage or infections such as pneumonia. This concludes the video. We would greatly appreciate if you would provide feedback by clicking on the link. You will be directed to a short survey which we hope will improve this process in the future. Thank you for your help.